let me just make sure here.
Yeah.
Hello, everyone, and thanks for joining us this evening for me and for Dr. Candow. It's a different time, of course, wherever you're watching from. I hope everyone's doing well, and thanks for joining us for the Advanced Exercise and Health Science Forum, Session 8. My name is Gianni Parise, and I will be your host for this event. I am a professor at McMaster University in kinesiology in Ontario, Canada. And today we're privileged to be joined by our speaker, Dr. Darren Candow, who's a professor at the University of Regina in Saskatchewan, Canada. I'm particularly pleased to be hosting this event as I've known Dr. Candow for over 20 years, and he's not only a colleague, but he's also a good friend. Dr. Candow's work, I'd characterize it as sitting at the nexus of nutrition, exercise, and health. He's the director of the Aging Muscle and Bone Laboratory, and his research goals are focused on developing lifestyle interventions that have practical and clinical relevance for improving muscle, bone, and brain health. He's published over 130 peer-reviewed papers and has attracted funding from multiple provincial and national funding bodies, as well as industry partners. Today, he's going to be speaking to us on the effects of creatine supplementation on musculoskeletal aging. And with that, Dr. Candow, I'll pass it over to you to share your screen and begin your talk.
Great. Thanks, Dr. Parise. It was a privilege and very flattering introduction. I'm very excited to be here with everybody. So I'll share my screen. Go all the way up here. So I believe everybody should be able to see that correctly.
Yeah,
hopefully.
Good.
Yeah, so I'm very delighted tonight, or for most people around the world in the morning, whichever time zone you are at, to talk about the effects of creatine supplementation on musculoskeletal aging. And that'll primarily focus on muscle and bone, but I'm really excited to sort of finish the presentation and introducing some of the beneficial effects on brain. For those who want to follow me, there's my handle at Instagram. If there is a lot of questions tonight and I can't answer those, I will try to answer those the best of my ability. So again, tonight we'll focus on muscle and bone primarily, and then again we'll get into the aspects of brain health. But creatine has really taken on a new life of its own, I think, from the health applications, which we'll get to very shortly. So as most of us know, creatine, all the way back to even high school biology, is made in our body. Tonight we will talk about supplementation, but it's really important to understand that we are making creatine pretty much on a daily basis. Most of us are familiar with a two-step process starting in the kidney and, of course, finishing in the liver. And very similarly, once it leaves the liver, it gets into systemic circulation and primarily goes to our demanding tissues. And for most of us watching, we are very familiar with skeletal muscle, athletes getting bigger, stronger, faster, and we'll sort of talk to that shortly. But if you have too much creatine coming into the body that's not utilized, it's very similarly excreted in the urine. But a lot of new technology has come about in the last few decades showing that the brain will also make its own creatine. So unlike muscle, which does not make creatine, our brain does. And that has some pros and cons as well. Since the brain makes its own creatine, it doesn't really rely on supplementation or dietary creatine as much. But are there ways to get creatine into the brain? That could have huge applications for clinical depression, anxiety, or cognition. So that sort of lays a foundation of where creatine is being made in the body. Of course, we also know that creatine can be consumed in the diet. The highest concentrations come in seafood as well as red meat. Maybe about 1 to 3 grams a day, depending on your habitual preference. But keep in mind, if you're a vegan, vegetarian, or emphasizing a plant-based diet, you're not hardly getting any dietary creatine. trace amounts again in dairy. But if you're on a carnivore diet, you're actually getting probably 1 to 3 grams of creatine. And that begs the question, is supplementation required? By the end of the presentation, hopefully you'll be able to answer that. But at the end of the day, is supplementation required if you're either making creatine or you can get through the diet? I think it can be difficult depending on where you live in the world, and obviously with the sustainability, environmental effects of animal being used as a source of creatine. This will sort of put it into perspective. To get as little as 3 grams of creatine, you would have to consume an entire kilogram of codfish. To get 4.5 grams of creatine, you would have to consume an entire kilogram of beef and all the way down. So this can be achieved, but depending on where you live in the world, it's very, very difficult. And here in Canada, the cost of seafood and red meat is very, very costly. And I imagine it's the same worldwide. So are there alternatives? And I think this is one of the few compounds where supplementation is probably equally or more attractive than the diet. Unlike caffeine or protein, which you can obviously get through beverages or food products, to get the amount of creatine, which we're going to talk about tonight, through the diet can be done, but then again, it comes down to your habitual dietary intake. What happens if you're a vegan or vegetarian? What happens to the expense of seafood or red meat? But that's why supplementation has become so popular. And it's important to note for the rest of the presentation, when I refer to as creatine, I'm only referring to creatine monohydrate. That's simply a creatine molecule linked to water. And when it comes into the body, when it goes through the hydrochloric acid of your stomach, the water molecule is dissolved. So that creatine molecule is identical to what's being produced in the liver as well as the brain. So the safety profile of creatine monohydrate is exceptional. It's right up there with, protein and caffeine from a research perspective. But the safety profile is so good, probably because our body's producing it and or recognizing it. So a little bit of background on some metabolism, but the main purpose of why creatine, it was discovered in 1832, actually discovered before ATP was, but the whole theory here is that creatine, when it's phosphorylated, it became phosphocreatine, and we're all familiar with the anaerobic energy system, and if phosphocreatine stores are elevated, that will help maintain ATP or adenosine triphosphate, the energy currency of our cell, during times of intense exercise or metabolic demand. So hypothetically, if the individual is running all out, maybe if they're on creatine supplementation, they can exercise at a higher capacity for a few seconds. That may not have a lot of application for the average exercising individual, but the upcoming Olympics in Paris, this could have huge applications for those involved in high intensity or anaerobic sport. And this kind of goes with what you often hear a lot of gym goers say when they're on creatine supplementation. They seem to enhance the anaerobic energy system a little bit more. They can probably do a few more repetitions per set. They recover quicker between sets. And then, of course, strength goes on. So the whole theory here is if we increase creatine, that'll help maintain ATP longer, and that will delay slower energy systems such as glycolysis and oxidative phosphorylation. The vast majority of what we'll talk about subsequently tonight involves resistance training. And I like to put this in a pill form because I'm a big proponent of exercise. I think aerobic exercise is phenomenally beneficial to the human body. Resistance exercise, in my opinion, is equally as effective, if not more. Creatine really likes to work in conjunction with exercise, and that's primarily resistance training. So when we talk about bone or muscle, it's primarily based on resistance training. Some novel research is suggesting that maybe exercise may not be needed for brain health, and we'll talk about that shortly. So for the rest, when we get into bone and muscle, we're primarily looking at the combination of creatine with resistance training. So I always like to talk about bone first because it's an area often overlooked. I think when we look in the mirror, we always see our body. We never consider bone. We always consider muscle mass or body fat. But as we get older, especially for females or biological females, bone loss is very, very important. And so I was very fortunate to sort of perform one of the first small-scale studies looking at the effects of creatine and, again, resistance training in postmenopausal females. And this was really important in Canada because postmenopausal females have a high rate of osteoporosis or falling, which leads to hip fracture. And so in this first study that we did, we looked at 32 postmenopausal females. They were postmenopausal for 12 months, and the average age was about 54 years. they were randomized to a dose that you may not be familiar with. More times than not for athletes, we typically recommend 3 to 5 grams a day or a loading phase. What we've speculated is that as you get older, you may need a little bit more creatine, very similar to the idea around more protein to offset sarcopenia. So we've used this dose quite often, 0.1 gram per kilogram. So if you're 70 kilograms, that's 7 grams a day. If you're 100 kilograms, that's 10 grams a day. We combine that with 1 year of supervised whole body resistance training. A typical whole body program you do 3 days a week. The theory here is that we want to do a long-term training design because bone takes a long time to turn over, and to notice any statistical significant effects or small effect sizes, you usually need a long-term intervention. And some of our most novel results, and this was measured by DEXA, was around bone mineral density. And it's quite interesting. Remember, these individuals trained a whole year, 52 weeks, supervised. And now we're looking at the change in the femoral neck or the bone mineral density around the proximal hip region. And you'll notice it was minus percentages in both. So that immediately tells you the biological process of aging is accelerated in postmenopausal females. You may speculate maybe it's estrogen that's playing a role. But you will notice that there was a lot of variability in a small scale study. But on average, the individuals taking creatine only lost 1.2% of bone mineral density at the hip, whereas the females on placebo lost almost 4%. And keep in mind, if you hit 5%, that's clinically significant, and that leads to a 25% greater increase for fracture. So we were very surprised and fortunate to find these effects. Although it was a small scale study, it was showing that creatine maybe preserved bone mineral density around the hip, which could have application for maybe osteopenia or osteoporosis a little bit later on. We sort of wanted to take it to at the next level and say, maybe if we did a longer term training with even a higher dose creatine, could that have a greater effect and in an adequately sample sized population? So this study was 2 years of creatine in an adequate population of over 200 postmenopausal females. The average age here was a little bit later. And then they engaged in 2 years of supervised resistance training and 6 days of walking. So what we sort of replicate from what we're trying to promote from an aerobic and resistance training perspective. And you'll notice here that we slightly increased the amount of creatine a little bit more, 0.14 grams. So on average, the females were getting 11 grams of creatine monohydrate a day for 2 consecutive years. And some of the novel findings. So bone strength is now recognized by the World Health Organization as a main predictor for osteoporotic fracture. Again, looking at the femoral neck or around the hip, you can see that even 2 years of creatine and supervised exercise had a maintenance of bone mineral density and bone strength around the hip region. However, those on placebo had a slight reduction. So clearly showing now that the accelerated process of aging in postmenopausal females cannot be totally overcome with exercise. When we look at bone buckling ratio, and this is something you don't want, that means the bone will fracture quicker. Creatine actually preserved the buckling ratio. But again, look at this. The incidence of breakage went up on placebo. So at the end of the day, those are two simply showing that creatine and exercise preserve the skeleton in postmenopausal females. But if you just did resistance training and walking alone, it may not be enough. So this is something to consider when we look at long-term interventions. It's logical to ask, well, what happens if postmenopausal females did not exercise? That would probably be catastrophic. These numbers would be very, very reduced. So I think one of the main take-homes here is, independent of creatine, please exercise and then look at adequate nutrition as a small adjunct to that. A limitation of the previous 2 panels is that we did measure bone through DEXA, which is kind of a 2-dimensional, or measures the aerial properties of the bone. But we are fortunate to have CT scan, which gives a 3-dimensional imaging of not only muscle and bone, but it also looks at trabecular and cortical bone as well. So we actually did another study 1 year in training and included now males and females. Again, the dose was 0.1 gram per kilogram, so on average about 8 grams. And this was quite interesting. Now we're able to look at distal tibia area and tibial shaft area with PQCT. And again, now this is really starting to support the DEXA findings. the creatine group experienced a greater change, positive, in area under the knee in both the shaft and the distal tibia. And this is interesting because when you fall on ice or snow or whichever it is, it's the muscles and these lower bone areas that are very susceptible to breakage. So the nice thing here, complementing with the previous two slides, is that creatine and exercise can have some favorable effects now on bone area and size. We think it is almost approaching clinically significant in a long-term trial down the road because bone strength and area are significant predictors of hip fracture. Here in the small country of Canada, we spend almost $700 million just on hip fracture alone. And obviously, you're going to multiply that by 10 in the United States and obviously exponentially in the continent of Asia. But hip fracture is a main cause of functional impairment. So if you do suffer a breakage or hip replacement, you're usually inactive for at least a year, which leads to a lot of other metabolic diseases such as metabolic syndrome, obesity, and cardiovascular disease. We really don't know how it works in total, but we think we have some clues based on some in vitro and in vivo data. But creatine is used as a fuel for our osteoblasts or bone building cells. And if you can remember back to some of your university undergrad days, if you have the osteoblast cells more energetic, that will start to sort of stimulate more calcium and phosphate salts to be packaged in to the bone matrix. But one of the other cool things that's not often brought up is that osteoblasts, they stimulate this cytokine. It's called osteoprogerin, or abbreviated OPG. It acts as a decoy for rank L. And therefore, it's kind of like when you consume caffeine, the adenosine receptor is sort of blocked. By blocking this, you decrease osteoclasts, or those cells involved in bone breakdown. So one of the logical theories here is that maybe creatine will stimulate osteoblasts, and that's bone building cells, but at the same time, it may reduce osteoclast activity. So when you combine the totality of this, very similar to muscle protein synthesis and breakdown, maybe that's having some favorable effects on bone strength and area. And it's very difficult. There's only a few labs in the world that do bone biopsies. One is in the Netherlands, and a lot of other times it's very hard to get past ethics. But what you can do is take some very acute urinary markers of collagen breakdown. So NTX is abbreviated for NTL peptides, a measure of type 1 collagen. And when we gave creatine 0.1 gram per kilogram for as little as 10 weeks, we did see about a 30% reduction in this marker of osteoclast formation. There's other labs, even at McMaster University, where they looked at osteocalcin, a precursor for bone synthesis. It wasn't increased, but there's been other labs to show it has. So we think there's some mechanistic data, but long-term clinical trials need to be done with that, especially looking at the osteoblast itself, osteoclast, and of course, osteocyte activity. The other logical theory is that it may have some direct effects from a cellular perspective, but creatine is well known with exercise to put on lean or muscle mass. And the logical thing here is with the muscle-bone interaction or crosstalk, maybe if the individual has more muscle mass, it's pulling on the bone throughout the day. And over time, maybe that would stimulate some bone activity, and that can't be ruled out. So in summary, we think creatine from a bone perspective may have some direct and indirect effects. So in summary, the preliminary data, and there's only a handful of studies, but some have been really well designed at adequate power. The combination of creatine, please note the dose. 3 to 5 grams, which is typically recommended for muscle at a young age, is not sufficient enough. The lowest dose is about 7 to 8 grams a day. And resistance training, typically for the long duration, can have some small favorable effects on bone area and geometric properties. This may have application for clinical populations. It can decrease urinary measures of bone breakdown, but at the end of the day, we can safely conclude now it does not increase bone mineral density. We've done a 2-year study. Some of the reviewers suggested maybe a 5-year, or maybe look at osteoporotic individuals. Maybe they may be more responsive. So those are some of the things to consider moving forward. Now we'll probably get into an area that's probably more prevalent or applicable for a lot of the viewers, muscle and lean tissue mass. And I was part of a large meta-analysis. There's been about 5 now performed worldwide, but this is the largest one. And we wanted to look at all the effects of creatine and resistance training on measures of lean tissue mass. And so this was measured by a plethora of technology: DEXA, bioelectrical impedance, BOD-POD, and underwater weighing. 22 studies were included. We actually looked at over 700 older adults, 50 years and above. They had to be randomized to creatine or placebo. And please note they were training, 2 to 3 days a week, which aligns with the North American guidelines for resistance training progression for 7 to 52 weeks in duration. We'd like to update this meta-analysis now with including our study that did 104 weeks, and that'll be coming out shortly. But this data really mirrors a lot of the other meta-analysis. So when individuals will consume creatine and perform resistance training, on average, they get about a 1.4 greater increase, kilogram increase in lean tissue. But I want to highlight a little bit of caution here. Remember, these are measured from a whole body perspective. There's a lot of downfall when you measure just lean tissue mass. It includes a lot of other things: fibrotic tissue, water, organs, blood. But it's a safe estimate that you consider whatever the number is in lean tissue, half of that may be dry muscle. So at the end of the day, if you say, hey, we improved 700 grams of muscle mass in the older adult, I think I would take that, because remember, this population is undergoing age-related loss of muscle mass. Not only is creatine and resistance training maybe preserving it, you might get a small beneficial effect. And please note that lean tissue mass is still a viable measure, as it's a big glucose disposal, and that has implications for type 2 diabetes. Again, going back to the previous studies when we looked at bone and measuring PQCT, it's very nice because it's a three-dimensional technology that can measure muscle density or muscle quality. And this was quite interesting in the individuals that performed a year of resistance training. Lower leg muscle density went up. So now we're starting to see a whole plethora of bone potential benefits, and now muscle and lean tissue benefits as well. And then finally, we started to do a meta-analysis this year looking at regional measures of hypertrophy, primarily looking at B-mode ultrasound. Ultrasound is a very viable tool if done correctly, and it's portable, so that's nice. You can go to rural areas. Now, keep in mind, there was only 6 studies included. 5 used ultrasound and 1 used our PQCT. 282 participants were randomized. And what it showed is that creatine and resistance training resulted in a small but significant increase in muscle growth over the whole body from an ultrasound. The effect size was small, but it still had a favorable effect from a positivity standpoint. Probably what's just as important, or some would argue more important than lean tissue mass, is strength. In Canada, lack of strength is the #1 reason older adults are placed in long-term care facilities, and performing activities around the house, carrying groceries, shoveling the driveway when it snows. Those are really, really important functionality measures. And when we go back to that meta-analysis I previously showed on lean tissue, we found by a large effect size that creatine and resistance training had favorably greater effects on upper body strength and lower body strength more than placebo. So the probability of these findings was a lot more significant than lean tissue mass. And I would probably venture a guess, for everybody listening, you probably are well familiar with the effects of creatine on strength. That's kind of where the greater totality of evidence lies. And we think this is important for older adults, especially in the lower body, because those areas are more negatively affected with aging. When you sort of divide the body up, maybe older adults don't use the lower legs nearly as much. They take a vehicle to work, escalator up the stairs, whichever it is. Maybe performing activities around the house or outside require more upper body strength. But please note the lower body strength has the largest muscles, and if you don't use those, we go through preferential type 2 muscle atrophy over time. So not only is it important to work out the whole body, it's really important to focus on the legs, especially when you get from the 4th decade on. And we think creatine and resistance training can have some favorable effects. But just by improving strength and muscle mass, does that actually improve activities of daily living? So we're really interested in functional ability, and now this is highly being used from the diagnosis of sarcopenia. And we've done another small meta-analysis looking at sit to stand, so getting off a chair, which has huge implications for older adults getting out of bed, off the toilet, or getting up from the dinner table. And this is interesting when individuals consume creatine and, again, perform resistance training. It was technically significant at 0.05, but having a favorable effect showing that some activities or functionality measurements can go up. We also recently showed in stroke rehabilitation patients that the 6-minute walk test improved as well. So there is some emerging evidence showing that the combination of creatine and resistance training not only will improve muscle mass and strength, but also have some potential benefits for functionality. And this has huge implications for those susceptible to osteoporosis and sarcopenia. How it likely works. So this is way more complex than bone. I'm not going to spend the next 14 hours trying to elaborate and go through all this, but I'll just highlight a few things that we're very confident based on a number of accumulating studies. So we think it has muscle anabolic processes. So we think there's a replicated studies now that creatine can increase IGF-1 content and mRNA expression. There's evidence that it can actually improve myogenic regulatory factors or transcription factors involved in translation. As Gianni would know, it actually has beneficial effects on satellite cell activation. And therefore, the satellite cells may donate more nuclei to the myonuclear domain. Could that increase transcription of proteins? All of these have been touted to have or help explain why creatine may lead to improvement in lean tissue mass and strength. It has been shown to improve some of the kinases in the mTOR pathway. Quite interestingly enough, a few studies have not been shown that creatine directly increases myofibrillar protein synthesis. That's in its works, but where it's a combination of non-essential and essential amino acids, and it doesn't have all 9 essential, it kind of makes sense. Maybe that's why it doesn't have an increase in muscle protein synthesis directly. Dr. Parise and myself, we've shown in a few different studies that creatine has application to decrease markers of muscle protein breakdown, primarily in males, and maybe estrogen is involved there as well. And this is the interesting thing on the right, is really starting to emerge by creatine having anti-inflammatory effects in the brain and muscle, and it has some implications for glycogen kinetics. So when you put all these things together, we conclude it has some muscle anabolic processes, and it also has some muscle catabolic processes. It seems to recover the environment of the muscle a little bit more post-exercise, which may allow an individual to exercise at a higher capacity. So where are we? Well, you can see here the check mark. We know a lot more in younger individuals under the age of 40. We now know that creatine is involved in phosphate kinetics. It's been shown to increase IGF-1, myosin heavy chain expression, satellite cell activation, all the way down. But again, there's an X by protein synthesis. But look at the question marks in older adults. We have no idea about the effects of insulin growth factor 1, mTOR, satellite cell activation. There was one study, but it needs to be replicated. And again, we have no idea about the effects on protein synthesis. So we sort of use all the data in younger individuals to try to extrapolate older adults. So I'll spend the next 15 years of my career trying to look at some of these pathways. And then how does that influence bone and, which we'll talk about shortly, brain. So the muscle summary is a lot clearer than bone. We now know that it's increasing whole body lean tissue mass. This is important for offsetting type 2 diabetes because lean tissue is a main site of glucose disposal. For those rehabilitating from an injury or trying to improve, maybe offset a bilateral deficit, there is some beneficial effects on a regional or isolated muscle size. Really important that it improves lower limb muscle density or quality. That may have implications for withstanding falls or maintaining activities of daily living. And I did put a star here by, I think, really important for the aging population worldwide is that it improves upper and lower body strength. And then finally, I'm really excited to sort of talk about some of the emerging area. I think this is the hottest topic right now. I was in Paris last summer just talking specifically about creatine in the brain, and this has really taken on a lot of momentum. A lot of us don't know or do know that brain is very metabolically demanding, especially when you're stressed. So sleep deprivation for academics watching, writing grants, teaching, a lot of individuals working overnight. The brain is always sort of being taxed in today's society. And it uses about 20% of your energy. And what we now know is just like our muscle, that the brain cells use phosphocreatine to help maintain ATP levels. So the theory here is, what if we gave a supplement in circulation? First off, can it get in the brain? And if it does, what are the effects? When you look at the small body of evidence, there's about 12 studies now that have looked at creatine and brain accumulation using magnetic resonance spectroscopy. unlike muscle, which gets about 20 to 40% an increase, creatine in the brain is only about half. So there's some ideas about why is it only half the amount compared to muscle? Well, the theory here is that creatine can cross the blood-brain barrier, but it's very, very blunted. So these astrocytes do not have the creatine doorway or transporter. The oligodendrocytes do. So yes, creatine can get past the blood-brain barrier into the brain tissue, but it's very blunted compared to like muscle, which acts as a vacuum. It'll take in all the creatine that it can. So the protocol to do this is kind of multifactorial. The theory is that you're going to need higher dose creatine to get accumulate in the brain, because first off, creatine will go to your muscle. Maybe leftovers will trickle to the brain, but the vast majority will want to get into the bone cells as well. And then, of course, without having the doorway, the brain already makes its own endogenous creatine. So maybe the brain says, we don't want you from the supplement. We don't need you from the diet. But if you're compromised and the brain is suffering where it needs more creatine, that's when we think it can have an accelerated uptake. And that's probably why you're starting to see speculation around depression, anxiety, concussion. One of the common denominators in all those populations is that their natural or baseline creatine stores are reduced compared to a healthy control. So maybe the brain is more sensitive and it will take up more creatine from the periphery, circulation, or supplementation and get into the brain. And interestingly, we just published a new study with long COVID, and that was one of the cases. And the theory is maybe the brain was going through some oxidative stress. This was a very elegant study done by one of the leading creatine research groups out of Brazil, and they wanted to see is the effects of supplementation different from muscle and brain. And this was quite interesting. Now, keep in mind they gave 0.3 grams per kilogram, so over 20 grams a day for 7 days. And what you'll notice in that short period of time, even a high dose, there was no increase in children, adults, and the elderly. But if you flipped it to skeletal muscle, they all had an increase. So what this is simply showing is that to get into the brain and accumulate, we don't really know the optimal dosing. Maybe you need 0.3 grams for longer, or you may need some other type of adjunct with this. So I wanted to put this up there to show that it has promise in other studies, but there's also other evidence to suggest we just don't know the optimal supplementation protocol, and that's probably the focal point for the next few decades. We have done a meta-analysis looking at memory in older adults. And if you look here at the bottom in the small group of studies, creatine, and this is again without regimented exercise, it did improve aspects of memory in older adults, which has huge potential for dementia and clinical populations down the road. We don't know the mechanisms. When we go to the animal model, one of the common mechanisms that creatine has been shown to do is reduce oxidative stress. So under times of metabolic stress, aging, sleep deprivation, jet lag. So for example, maybe creatine would be advisable to maybe decrease some of the inflammatory markers, and that might help increase cognition and memory. So that's what we speculate. We just don't know fully. Some of the other areas of interest in ALS, there's been no beneficial effects. And even in Huntington's, Parkinson's, and MS, there hasn't been a totality of evidence showing a great positive effect there. We think one of the big reasons for this is the sample size, and these pilot studies have been very, very low. I do know of one study that has been ongoing in the United States in Alzheimer's disease, and I'm very excited to find out the results of this, because this could be a groundbreaking from a clinical health and global health population. So again, it's an emerging area. It had some applications for concussion treatment in children. But again, if you are watching and this is an area of interest, please message me on Instagram and I can send you these studies. We were fortunate to put out a big review just this year. So the brain summary is very limited. Creatine supplementation, what we currently know is 20 grams a day for 7 days. That's referred to as a loading phase. Or there's other good evidence to show that little as 4 grams a day, but again, for several months. It's probably because it needs to accumulate over time. It can increase brain creatine levels. We don't know the effects in older adults of healthy and/or clinical populations, but we do know it has some potential to improve memory in older adults. And I think this is the area that you'll see a lot of future research going. So I love this diagram from a few of my colleagues. So when we look at preventative creatine supplementation and therapeutic, if your creatine pool is adequate, if you're getting adequate sleep, your diet's fine, adequate amounts of sleep or dietary intake. If you do suffer from acute stressors, that may reduce the creatine pool a little bit, but it's still sufficient. However, when the creatine pool is already insufficient, so think of clinical depression, anxiety, PTSD, concussion, sleep deprivation, a common denominator is that your brain, phosphocreatine, and total creatine pools are already compromised. So therefore, when you do have a stressor, it's going to be reduced. Hence, supplementation may be needed to bring those levels up. So that's the theory over time why creatine supplementation may have some applications, and I think you're going to start to see an emergence in research with that over time. So I want to thank you for your time. Again, I apologize if I can't get to all the questions. There's my handle at Instagram. Please follow me or direct message me, and I'll try to get to you as best as I can.
Okay, thanks, Darren. That was great. Appreciate you taking the time to put the presentation together for all of us. It was definitely informative. We're going to start out. I have a number of questions I'd like to ask, and of course,
Would you like me to stop or maybe stop sharing my screen, or it doesn't matter? Or...
Yeah, sure. Let's do that.
Okay. Perfect. There you go.
Okay, and what I'll do is maybe I can start with a few questions, and of course, if I see questions coming up in the chat, I'll share those with you as well. I mean, some of the more fascinating data that's coming in now is associated with the work on brain, only because we know so little about it, I think.
Yeah.
There's a pretty large body of literature on the impacts of creatine on muscle, as you highlighted, but the work on the brain is really just getting started, I think. And my first thought was, I was sort of surprised. I mean, I have to admit, I'm not familiar with brain metabolism, but I was sort of surprised on this reliance on the phosphocreatine energy system in support of brain metabolism. Is that can you comment on that at all? Is that common knowledge that the phosphocreatine system is a utilized system in the brain?
Yeah, no, it's not common knowledge, and that's why we sort of got surprised about 2 decades ago when we started to see these studies from the Belgium was one of the first studies they were looking at in rodents, and we always knew, when you're in university or whichever, the creatine kinetics, we always talked about muscle, and we didn't even know at the time about bone turnover, and now the brain. And then when we look at all the mechanisms, the mitochondria comes in, oxidative stress, and that's probably why it only seems to work when the brain is metabolically stressed. Like if you're a young individual, adequate sleep, nutrition, you're not going to notice any cognitive or memory effects. But there's now study after study coming out. Sleep deprivation is one of the best ways to sort of metabolically stress the brain. And it uses the phosphocreatine system the exact same way as our muscle. When our muscle is stressed, it gets sore. We just are always, mentally fatigued or sleep deprivation. So personally, when I fly to Europe or a long duration flights, I'll really increase my creatine dose, and hopefully that'll have some beneficial effects, especially on sleep. I find, when you're sleep deprived, it has those areas to be less foggy. So you're right. We probably always knew it. It just hasn't come to light until the last 2 decades. Yeah.
Right. Yeah. It's so interesting. And it got me thinking, is it possible that the role of creatine in the brain may be broader than we appreciate in muscle? Is it possible there's another function of creatine in brain cells that we just don't appreciate because we're so focused on sort of the canonical pathways in muscle that we're aware of? Is that a possibility, or has anything been?
Yeah, it's huge, because then you'll see some studies that look at gray matter, white matter, different areas of the brain, frontal cortex. I would venture a guess, for those interested in this, the next 20 or 30 years with advanced technology, and that'll be a huge area to look at the mechanisms. And then in clinical populations, those undergoing hypoxia, the Paris Olympics coming up. I'm getting questions now, not from muscle, but can that athlete have more cognitive focus near the second half of soccer match for whatever it is, the World Cup coming up? Those are areas which seem to be taking over, which is fascinating to me, because we think we knew everything about this molecule since the 1990s. And then we got into some bone, and then the anti-inflammatory effects. We never thought a creatine really had application for aerobic exercise, and now it seems to reduce those inflammatory cytokines. So this molecule is gone from an exercise, bigger, stronger, faster, to sort of health beneficial effects, and the brain will be the big focal point for sure. Yeah.
Yeah. Now, what's the optimal dose to drive creatine in the brain? You mentioned it in your talk, but it's around 10 grams.
Yeah, it's an excellent segue. So we think, from a muscle perspective, for summary, 3 to 5 grams is probably viable for most. The bone may need a bit more, but we're still on the fence with the brain. It seems that on average, you either need the loading phase, 20 grams a day for at least 7 days, or at least 4 grams a day for several months. So one of the logical things here is, if 95% of creatine is in muscle, you're going to have less than 5% going to your brain or bone. So that's why we think you need higher amounts in circulation. Once the muscle is full, then it may trickle to areas in demand.
Right. And is there any danger in, I mean, are there side effects of dosing? I'm wondering, with muscle, we know that you can really get away with maybe, 2-3 grams a day every day. But if you're now dosing for the brain, are there potential side effects that one might suffer?
Yeah, it's a huge area of question and potential concern. So you're right. We kind of know now that the muscle can take a lot. But when we've done I guess the best way to answer that is that long-term study where we looked at postmenopausal women for 2 years at 11 grams. We did not measure anything in the brain, but we did measure liver and kidney enzymes, and they were not greater over time. So we're confident from at least a soft or musculoskeletal perspective. But you're right. What about for stroke rehabilitation? If where creatine is osmotic, could water be getting in? Could that have pressure on some cells? That's an area that we definitely need to look at. What are some of the potential side effects in the brain? We now know there's benefits. We're starting to see people have more energy, decrease anxiety and depressive symptoms on medication. But that's an area, maybe, your colleague Mark Turner-Polsky and people like that can start to look at some of the mechanisms in the brain. But there's a big group out of Utah that are starting to look at that, and that needs to come out before we can confidently say it's a whole body supplement. We know at least from a potential health benefit, but we have to look at it from a safety perspective for sure.
Right. And so on the heels of that, are companies marketing creatine for brain health yet, or are they allowed to market on label for brain?
It's starting to come out. What I've noticed is they'll say it boosts cognition or it'll boost memory based on some of the findings. So it is interesting, like Health Canada or the FDA, they haven't come out with, their position stand on offsetting it from a muscle perspective on labels. Nothing on bone that I'm aware of, but I have started to see a lot of companies really take off on this brain potential. But again, there's caution because we're sort of anecdotally looking at that over time.
Okay. Let's shift gears for a minute here, because I know when you started speaking about at the very beginning about bone,
Yep.
I was surprised to see that there was a 4% loss in bone mineral density in women who were exercise training for an entire year. What would you expect that to look like in women who are not exercising or something? Because I think that's a shocking loss of bone mineral density.
It was shocking. Now, keep in mind that the sample size was low, so a little bit of caution was there. It could have been a little bit by chance, but when we did look at their percent change over time by DEXA, so it needs to be corroborated with some other longer term studies. But I will highlight the group out of Brazil who did the same duration of exercise as we did for 2 years without exercise, and they found no beneficial effects over time. So the question comes, what if you had a group of postmenopausal females who did not exercise? Would that percentage be even larger? It's logical to say, yes, we just need to have that in a new randomized control trial. But we also got to look at what is their level of vitamin D, protein, and calcium. Were they susceptible to osteopenia or osteoporosis? So again, a few more clinical trials would need to be done for sure, but it wasn't a substantial loss from a percent perspective. Yeah.
Thanks, Darren. Do we have a question?
Yeah, hello, Johnny. Hello,
Hi,
Darren.
how are
It's
you?
a really
Hi.
wonderful talk. So,
Thank you.
I'm actually not doing clinical study. I'm mainly doing vascular biology, but
Okay.
always learn a lot from these kind of talks. So I do have some really simple questions for you, I think. So because we work on the vascular side, so in the textbooks, it always says like exercise increase capillary density and all that kind of things in the bones and in the muscles. So in like any of your clinical studies or based on like your insight, do you see any like these kind of changes on capillaries or any influence from the creatine? Maybe I don't know, like during aging or when you give them exercise.
Yeah, there's been a few studies looking at individuals post surgery, so cardiac rehab, and they've only looked at some of the health beneficial effects on stroke volume and heart rate, but they've never looked at anything from a arteriole or venule or capillary density perspective. I think that would only work if the individual was doing aerobic training. I mean, if you do a resistance training with high volume, you maybe get some capillary density or number go up, but to answer your question, no, there's hardly anything out there. And if you're willing to look at that, that'd be a very interesting population to look at and measure for sure. Yes.
Yeah, because from our side, so we had like put the mice on treadmill exercise and like all kinds of like mixed type exercise for quite a long time, I guess like 8 weeks something. But we try to look at the capillary density and never see anything that's significant. So I was wondering whether maybe it will be more obvious in aging or other kind of contests. Yeah.
Yeah, I mean, if you could show it in aging, that would have massive implications for anybody susceptible to metabolic syndrome or cardiovascular disease, or more importantly, stroke. So, yeah, if you're interested in that, keep going and provide more data. But that's a huge area of potential global healthcare purposes. Yeah.
Sorry, if I can just jump in really quickly. So when you exercise train your mice on the treadmill, you don't see increases in capillary density.
So let's be honest, is that our mice are like quite young, and we have someone like maybe on high-fat diet, that kind of things. But we see weight loss is really huge, but we never see like on histology or using other method to quantify the numbers. We never see like a really huge increase of that. So because that's in textbooks, right? Everyone says capillary density would increase if you give really maybe exercise for a longer time, but not really a big change to my surprise. So yeah, that's always been a puzzle. Yeah.
What kind of mice? What background?
Like the Black 6 background, mostly Black 6 background, and yeah. So weight loss is really huge, and glucose, those kind of things are really huge, but not really on right, yeah, not really on capillary density or maybe arterioles, that kind of things.
Have you ever measured VEGF or sorry.
Yeah, so let's say if you put in specific markers, then you may be seeing some increase or decrease or yeah, that kind of things, but it's not really that big. I guess our baseline is quite healthy to start with. So if if you put in more stressors, then maybe there's a bigger change. I don't know. Yeah.
I think one of the challenges, we've seen this in our animal work as well, that when you're studying a mouse, and so we find this, when we try and do muscle damage studies in mice with exercise, it's really difficult to damage mouse muscles running on a treadmill. And I think part of that reason is that the forces are spread across 4 limbs in mice, right? In humans, it's 2 limbs. And so, I find that we get a greater adaptive response in people because there's 2 limbs carrying the load. Whereas in mice, it's spread across 4 limbs. And as I say, exercise-induced muscle damage in mice is really difficult to get on a treadmill. So maybe it has something to do with that. It's a really interesting observation.
Yeah, right. So Darren, maybe another question on one part that talk about the muscle mass between, I think it's some studies that you look back or retrospective study or something else. So do you see like in maybe ethnic difference in Caucasians or Asians? Yeah, like because people may have like very different body distribution, like upper body and lower body, the muscle mass are really different. So is there anything related to ethnicity or yeah?
Yeah, embarrassingly, all the creatine research lumps everybody into one, and there's not a single study that have sort of partitioned it out biological sex of males and females from an ethnicity or cultural perspective. Meta-analysis will often report where the studies were, but that's a huge area that needs to be looked at in detail, and that's really important because we now know there's bone differences but we don't really know in regards to creatine. Embarrassingly, no one's looked at that. Yeah.
Thank you. Yeah, Johnny. Yeah, just these questions. Maybe you can look up some questions on the forum. I don't know.
Oh,
Thank
that's
you.
great.
Thank you.
Yeah, thanks. I appreciate the questions. I can't actually see the chat room in the forum, so I don't know if, I mean, if someone can see it and there are questions, I'd be happy to have you post them, but I can't see them.
I can't see anybody yet.
Yeah.
Oh, we can't see either, so I don't know
Okay.
where the questions are coming from. They are broadcasting over different platforms, right?
Right. Okay. Well, if someone has a question, please jump in and let us know somehow. But Darren, if I can ask you some questions, some more questions about creatine supplementation, because as you know, like, I mean, you know, you're the global expert in this area, and we've been trying for so many years to really optimize the supplementation approach. And so I want to ask you some questions about that. The first being, does the timing of creatine supplementation matter, or is it just as long as you get it in a day, that's sufficient?
Yeah, I think the timing, the evidence-based research suggests that timing does not matter. You can take it at your convenience. It's probably because it needs to accumulate, unlike caffeine, which is more of a drug effect within 45 minutes to 60 minutes. So the nice thing is, if you're considering supplementation, you could take it at any time of the day, before your workout, during your workout, before you go to bed. There's studies that have shown that there's beneficial effects and no differences between the timing. So that's very nice.
Yeah. Okay. Very good. The other question related to that was, have many studies been done trying to look at creatine supplementation synergistically with other types of supplements, or you know, is there anything that can enhance the effects of creatine as a nutritional supplement?
Yeah, the pioneering work from Paul Greenhalgh came out, a few decades now ago, showing a physiological dose of sugar or carbohydrates, which I think most people won't entertain anymore, seem to cause insulin spike, and it sort of opened the GLUT4 doorways to allow creatine kind of in through the transporters. But again, you're familiar with the work with protein. I think protein is a better health consideration from a nutrient perspective. You get the beneficial effects of protein. It is insulinogenic, but it can cause an upregulation. I always look at Roger Harris's elegant study from 1992, and for those familiar with creatine would definitely know about it. He clearly showed that prior muscle contractions augmented creatine uptake into muscle, and what that means is exercise. So when you exercise and then take creatine, the blood flow kinetics, the doorways are turned on. So although the timing doesn't matter, I always tell people, if you had to choose a great time, why not take it in your post-workout meal or a little bit later on? Some of the kinetics are turned on that way. But protein, i.e. whey and/or creatine, seem to be synergistic. And I know you've just published a recent paper looking at a multi-ingredient compound. And when you look at these compounds, there's only a handful of things that usually go together, and they're usually calcium, vitamin D, maybe omega-3s, proteins, and a little bit of carbohydrates. But that sort of encompasses the food matrix. And keep in mind, creatine is in red meat and seafood and poultry. But if you can't get that, maybe that's why you need to choose supplementation. But I know you're familiar with Nick Bird. He's always talking about food first, the food matrix. And if you can get creatine through your diet, that's fantastic. But for those vegans and vegetarians, or allergic to seafood especially, it may be a little bit difficult. So that's why I think supplementation could be an option.
And I mean, it's relatively inexpensive, would you say?
Yeah, it is. It's still
easier.
probably the cheapest, or it's probably still the cheapest, safest, and most effective ergogenic aid that we can get. Is probably even right neck and neck with caffeine, or a little bit more from a safety profile. Again, you don't need a very much. You could probably start as little as 3 grams a day and see how you respond. But on average, a tub of creatine, which would last you maybe 6 weeks, runs you less than $100 Canadian, which depends on where you are in the world. It's not that much money. So
might be worthwhile.
Yeah, could be, yes.
Yeah. One of the other things that I noticed in your presentation was it appeared that older adults require more creatine. Why is that?
So we never determined this, but we started to notice a little trend in our clinical trials when we gave 0.1 grams per kilogram. It was effective, but then other studies showed it was almost significant. In other words, we were like, well, what if we did a longer training study or a little bit higher dose? And so similar to aging anabolic resistance with protein, we showed in a meta-analysis that the bigger muscle areas in the lower limbs were more impaired from a phosphate kinetic perspective. So the theory, whereas maybe older adults 50 and above may need more to offset some of the impairments of phosphocreatine metabolism, and then parlay that into some of the benefits. So I personally take about 10 grams a day. I'm trying to hit the muscle, bone, and brain effects. But as we get older, maybe that dose could be a viable option for older adults. And again, you can break it up into smaller dosages, maybe 3 grams in the morning, 3 grams with lunch, 3 grams with supper. It doesn't have to be specific. I take 5 grams in my breakfast, and then I drink 5 grams during a workout. The cool thing is, once your muscles are full, it takes about 30 days for those levels to come back to baseline. So if you're traveling and say you don't want to take your creatine or whichever, please note the benefits or the elevations will last at like 4 weeks in the muscle, and it seems trapped longer in the brain, about 5 weeks. So it's very convenient. I think consistency, just like working out, is one of the most important things. But you could take as little as 3 grams a day, and as little as 30 days or 1 month, your muscle stores would be completely full. So again, that's 1/2 of a teaspoon. That's 1/2 serving of salmon or red meat. So it's not a lot, but again, it's consistently take it every day. Yes.
Okay. I have a couple questions I want to get to before we finish here. And I know we only have a few minutes left. One, I think this is really important. Are there sex-related differences in the response to creatine?
So it's interesting that of the sex-related differences, we thought that females, if they have a smaller skeletal muscle mass, they might have a higher concentration. And that was shown back in the 1970s, but it's never been really replicated since. So both biological males and females respond very favorably to supplementation. But the few studies that show some sex differences, we've actually published independently, showing that females just don't get a reduction in protein catabolism with creatine, either through leucine oxidation, which you've shown, or 3-methylhistidine, which is a surrogate marker. The speculation there is maybe estrogen is involved, but we can't rule out any other hormone. So when you look at the total body of evidence, we conclude there's no biological sex differences in response to creatine, except maybe from a protein breakdown or lean tissue mass growth perspective.
So sorry, just to confirm, just to reiterate, females don't appear to have this anti-catabolic effect of creatine.
Nearly the same as males. And when we look at older females, their magnitude of increase from a lean tissue mass is not as high as males. So they both respond, but maybe not to the same magnitude as males, especially from a lean tissue mass perspective. We don't know why that could be, but we do think in older adult ages, the cessation of estrogen, where you're losing that anabolic hormone, might be implicated in females.
Right. Okay. Last question for you from me is, I've noticed that there are many types of creatine on the market. If you go into a nutritional supplement store, they've nano creatine, they got all sorts of things.
Right. Yeah.
Is there a recommendation, and is one better than the other? And if so, why?
Yeah, the recommendation from the scientific community is always monohydrate, and there's 2 reasons for that. When you look at the totality of studies, over 1,000 peer-reviewed articles clearly shows that the safety of monohydrate is second to none, and the efficacy. We don't know, when you look at all these other marketed forms, none has ever been shown to be superior to monohydrate, and we just don't know the safety. So for anybody considering supplementation, please focus on monohydrate. And a really good paper came out 2 years ago by Richard Kreider, looking at all the marketed forms of creatine, and at the top of the hill was always monohydrate from a safety and efficacy profile.
And wouldn't the secondary benefit be that monohydrate, I believe, is probably the least expensive isoform?
It's still the cheapest. Yeah, the boring white powder is still the cheapest. That's right.
That's good. That's good. Well, listen, I would like to, first of all, just thank you for taking the time and speaking to all of us today. This was really informative for me, and I really enjoyed your talk. I hope everyone else did as well. But with that, I will wish you a good evening. I know it's around 8 p.m. Where you live. It's 10 p.m. where I live, and I know it's morning where many other places. So I hope you all have a wonderful day, and thank you so much for joining us.
Thanks for having me, and all the best. Thank you again.
Thank you, Darren. Thank you, Johnny.
Thank you. Bye.
Hi, Darren. I'm Ning
Yes.
Chen. Yeah, because just now I have the meeting and I just joined in this. I didn't catch your talk, so probably if you can send your PowerPoint and so
Yes.
let me know it again.
I can send that to Johnny if that's okay, or if you want to message me.
Yeah.
Okay.
Okay. Thank you, and also thank Parise, Gianni, and Professor Ken, Xiaoyu.
Yeah,
Thank you.
No problem. Thank you. This is wonderful.
Yeah,
Darren,
I just come back for the meeting.
Yeah, no problem. I'm happy you were able to make it for the end here. We'll maybe you can see the talk on a recording if you have an opportunity.
Oh, right.
Very good. But Darren, there is a question somebody posted, and if you can answer it now, great. And if not,
Sure.
maybe we can get an answer from you. The question was, which tools are best to measure cognition with creatine supplementation?
Oh, that's a loaded question. So the best tools now are looking at some type of, to measure the best cognition, we usually do sleep deprivation or things like that to get to a tool. But we're starting to see the Stroop test is the best way to sort of induce fatigue to measure some of those effects. And so there's no universal type. So that's going to come out, but we know how to get to the cognitive effects. We just don't know how to measure it from a global substantiated effects as well. Yeah.
All right. Thanks for that. Okay. Well, with that then, Darren, we'll say goodnight to you, and I hope everyone has a wonderful day.
Thanks again for having me. All the best. Take care.
Thank you. Bye-bye.
Bye.
Hello. Thank you.